All right. So welcome everyone to the Living Well with Cancer presentation tonight. I am so pleased to welcome our guest speaker, Jessica Salamone, who is a certified genetic counselor from the Elizabeth Wende Breast Care's Genetic Counseling Program up in Rochester, correct? I think there's a few locations. Awesome. So she is going to lead a presentation and discussion on genetics and cancer risk assessment. If you have questions, feel free to pop them in the chat. I'm going to keep my eye on that. Or, wave around. We can pause. We're pretty informal. So I will let you take it away, Jessica. Thanks so much for joining us tonight.
Sounds great. Nice to see all of your lovely faces and have a chance to talk to you about something I'm really passionate about. I have the literal best job on the planet. I get to sit and talk to people all day, every day, about a topic that is near and dear to us, and that is about our risk for cancer. And so tonight, I am very informal by nature. So tonight, this is just a chat. I do have some slides prepared for us just to guide us and to kind of keep us on track. I'll begin to share those in a moment, but what I would love for you to do, you may write your questions in the chat. You can also just kind of speak up. This is really a conversation. I'd love to be in the same room as you. That would make me happy, but this will work as well. So the presentation tonight is really meant to help us begin to think about cancer in light of genetics. And so the job of a genetic counselor is really to sit and speak with people and help guide them through how their family history, personal history, and other risk factors can impact their risk moving forward. I have a couple of fancy titles. I am not fancy, but my fancy titles are Director of Genetic Counseling and Cancer Risk Assessment, which is just a way of saying that I meet and speak with people about risk factors. And then I just finished a semester at RIT where I teach students how to do this job moving forward. So whenever I talk to a group, I'd like to just give you an idea of where we're going for tonight. I'd like to talk just a little bit about genetics. I think we all have an idea of what that means, at least in this era. I'm going to talk a little bit about what genetic counseling and cancer risk assessment is. And then inevitably, there'll be people who say, I'm interested in pursuing some genetic testing. So again, my lens is around cancer genetics, but there are lots of reasons a person can see a genetic counselor and pursue testing. And when I present slides, I think through what's going to help us move the conversation forward. Feel free to, as I said, ask questions or tailor it to what you'd like to hear a little bit more about. So 2 days ago, we celebrated Mother's Day, and you could look in the face of your mother, if you are not adopted, and see a mirror of some of the traits you've been given. So I want you to think about your genes or your unique instruction manual. They give you your hair color, your eye color, your skin color, so many things about you. Essentially, my favorite sentence is genes make you, you. And so sometimes this manual includes a risk for an inherited disease. This is also known as a mutation. Again, cancer is our lens tonight. About 10% of all cancer can be traced back to a faulty underlying genetic component. And so genes get a lot of press around cancer, but I'd like you to know that most cancer is age-related or environmentally induced. Most cancer happens because we're getting older or we've done something to our body from the things that we're exposed to. We smoke, we drink, we take medications, we have stress in our lives, right? We're all coming off of 3 years of the most stress that we can imagine. But about 90% of cancer can be traced back, not to genetics, but to those other components. I want to make you laugh for just a moment. Think about all of the headlines that are out there that include the word genetics. And so right now, are you a bad driver? It could be in your genes. Scientists find the liberal gene, the Republican gene, the gene linked to optimism and self-esteem is out there. We are in a generation of people who have heard of 23andMe and Ancestry.com, and genetic testing is just kind of part of healthcare. It hasn't always been that way. When I first started genetic counseling in 2001, so a number of years ago, a lot of my early conversations were helping people center what the concept of genetic testing and genetics is. Today, much easier to be thinking about it. So in theory, genetic testing and risk assessment is really just a conversation where we take into account a series of questions about you, and it helps your healthcare team know what might be happening moving forward. So the power of genetic testing is that it can detect inherited disease. Think about when you go to a GYN, ladies, or men when you see your primary care physician. They may ask you a series of questions. They're trying to figure out what is your risk of a disease moving forward. So knowing your medical history allows your healthcare team to determine whether you're an appropriate candidate for genetic testing. There are three buckets of risk, if you will. The first bucket is the general population. We all have a risk of cancer based on the organs that we have. Jennifer listed that I work at Elizabeth Wende Breast Care. So breast cancer is the primary thing that I deal with. 1 in 8 women will be diagnosed in their lifetime. That is a shocking number when you pause and think about it. There are 8 of us, at least on this call, and 1 in 8 will be diagnosed. Second bucket risk of cancer is what we call familial, when you have a family member who's been diagnosed. So for me, that was my grandmother in 2015. My mom's mom was diagnosed with breast cancer in the same building that I work in, came in for her routine mammogram and ended up with a diagnosis. That pulled me from the general population up to familial, because now I have a family member with cancer. The third bucket is what I spend time figuring out, is who has a family history, and now I need to talk about it as genetic or hereditary, running through the family. And so you fall in one of those 3 categories. Every category has a risk of cancer. And so genetic counseling is really just this concept where you sit down with somebody, genuinely right at this desk over here, where people sit and they chat with me about the occurrence or recurrence of a disease in their family. So occurrence, the chance that it happened the first time. So I see a lot of women who found out yesterday they have breast cancer and they're meeting with me today to figure out the next steps. Or recurrence. Maybe my mom and grandma had breast and ovarian cancer, and I'm worried that I'm next and the train is coming towards me. It's a consultation service, so people come in, they pay a copay, we talk once, and we kind of proceed on. I'm often asked, how do you decide that you want to be a genetic counselor, and how do you find this path? I wanted to work in the medical field. I see we have an NP on the call with us. Most people want to help people and do something, meaningful with their life. I was super interested in genetics. Whenever they taught it, it was the thing that came natural to me. It wasn't stressful or hard to process. It felt like it immediately had an application. I didn't like other areas of science, but genetics, I could speak the language. And I honestly just heard somebody talk about a career lecture that said, you can line these things up and communicate with people in these ways. So what are the kind of core skills of a counselor? So if you're going to go and have a conversation with somebody, they need to understand genetics, a deep and broad knowledge. They need to be able to tailor that conversation in a way that when you walk out, you know what you were just teaching about or learning from them. And then strong interpersonal skills, the ability to communicate and talk about that complex problem in a way that makes sense. Anybody who's ever been diagnosed with cancer knows how scary the beginning of that journey is. And you start to hear lingo and language and things that are spoken to you in a way where you have no idea what it means. My job is to meet the patient right where they're at. Nobody feels brave at that first initial meeting, but as they get their legs under them and start going through the pathway, they feel a little bit better. So my job is to help people understand sort of the medical facts, the diagnosis. What is this gene chromosome business? What's the risk of cancer as it is associated with that mutation? And then what are some alternatives that you can deal with? Most people, when they find out they have a genetic mutation, have a period of time where they need to process and understand and learn what their options are. Around cancer, people can choose to screen earlier and more frequently. People can also choose to have surgeries to reduce their risk. So in Angelina Jolie removing her breast tissue, other famous individuals, tell their stories of hysterectomies, and lots of patients do that every single day. So there's two hats that I wear when I sit down with a patient. The first one is just the medical role, right? Assessing their family history, assessing what's going on from a 3-generation pedigree, diagnosing whatever genetic condition we think might be happening through blood or saliva testing, and then walking that journey with that person to try to sort it out and figure out what they need to do kind of moving forward. Now, this is why I became a genetic counselor, which is the supportive parts of this, right? My gift is to explain science information in a way that people can just process. It feels like it's a conversation instead of, high-level science-y conversation. Providing emotional support. Sometimes the thing I did in a day was hand somebody a tissue and give them a hug, and that is as fulfilling as anything else that we can do. And then sending them on to testing options and resources out in the community, support groups like this, where people can kind of get together and gain additional information. Genetic counselors can work in a variety of settings. I have chosen to work in that adulthood cancer kind of location, but you may know of genetic counseling when somebody's pregnant or trying to have a baby, or a baby that isn't developing normally. Cancer affects 1 out of every 3 people in their lifetime. Think about that. So an application of cancer genetics is really a widespread, useful scenario. So when a person sits at my desk, what do we talk about? We gather the following 5 kinds of topics. I need to know a little bit about the person, their personal history, their family history, what brings them in and what are they concerned or worried about. I have to teach them a little bit of genetics to make sure we're all on the same page. What is a gene? What is a chromosome? What is heredity? What is the process for testing and the logistics? If I'm ready to do this, what do I now do? Here at our clinic, that's a blood draw or a saliva specimen. COVID changed a lot of things for people. So my services used to be face-to-face, 10 or 12 visits a day sitting at my desk. Now we offer our services still in person for those who'd like to come in, but phone and Zoom are another way. And so I can communicate just like I'm doing with you here, talk through the testing process, and then we can send a saliva kit to somebody's home. So that's a really great way for somebody to self-collect and send it along. Finances always come into play. Will my insurance cover this? What is that cost? What does that look like? That's a very natural question. And then in any given family, who's the best person to test first? Because I may have 4 children and I'm most worried about them. Should they test or should I test? Or should my mom test? And who and how do we do that? And what does the domino effect look like? So when I take a family history, I'm asking people to kind of come in prepared about who they're related to and the best of their ability, what information is there. If you grew up in a family that openly spoke about health information, then you're going to come in prepared. You're going to know when people were born, when they died, what they died of. Some of us did not grow up in a family where they openly spoke about health information. Maybe it's because culturally they just didn't feel like it was something you needed to communicate to children, that this was an adult issue and we're going to keep it private. Sometimes it's just generational. Doctors and physicians didn't always share with patients, and patients didn't know what they had going on. Sometimes it was too late and people just died of something, of cancer, and they didn't know where it started or something. So genetic counseling is dependent on the gathering of accurate, detailed, and relevant information. So as I sit down to talk to somebody, I maybe have 30 or 40 minutes to tackle a whole session. So my family history, 3 generations, aunts, grandparents, cousins, siblings, needs to be 10 minutes or less. So I'm targeting my questions to get that relevant information that I need. It really does provide the basis for me to do what I need to do. There are breast colon cancer genes. There are breast ovarian cancer genes. There are breast pancreatic cancer genes. So as I'm looking through the family history, I'm trying to figure out what it is we might be concerned about. So the 3-generation family tree is called a pedigree. It's a diagram that records family history information. It's a tool that converts the information the patient is giving me into a standardized format. You may have the most amazing stepfather on the planet, but he is not biologically related to you. And in that moment, he may be the dad, but in that moment and in that setting, I need to get at the person who donated sperm to create you and to make that genetic connection there. It demonstrates biological relationships through the use of symbols. When I do genetic testing, I have a couple of goals. The first one is, how do I help this person customize their medical management plan? So if you've been watching the news over the last couple of days, there was something that came out from the U.S. Preventative Task Force around when women should be having mammograms. And there's some discussion about what age and how frequently, and then how old you should be when you stop mammograms. And some really smart people are kind of fighting back and forth. Should it be annual? Should it be every other year? The idea is that there's often not a one-size-fits-all approach. If my mom had breast cancer at 42, I can't wait until I'm 40 to get started. It might be too late. So I need to customize that and start 10 years earlier. My second goal is to determine the risk for certain inherited cancers. Maybe every generation of men in my family have had prostate cancer, and I'm here as a woman going, well, that doesn't affect me. No, I can't get prostate cancer, but the same gene that causes a man to have prostate cancer could cause me to have breast or colon cancer. So it could still be a clue as to what I need to be aware of. And so paying attention to those things. And then our whole goal of all of this is to save people's lives. I can't prevent cancer per se, but at least we can find it when somebody has a fighting chance against the disease. And how do we do that? By screening as early as we're supposed to, as frequently as we're supposed to, and in the best mechanism and fashion. So tonight I'm going to talk about hereditary breast cancer. This is a wordy slide, but let's just kind of break it down this way. If I start with a woman with breast cancer in front of me, about 7% of the time, she has a mutation in a BRCA1 or BRCA2 gene. Okay, you've heard of the BRCA genes before. They are the single most common cause of hereditary breast cancer, and they're superbly high risk. Individuals who carry a mutation in either of these genes have a condition that we call HBOC, which just stands for hereditary breast and ovarian cancer. It's just a descriptor of what's likely to happen within that person. A normal woman's risk of breast cancer is 12%. A woman with a faulty BRCA1, you can read that third bullet point there, has an 87% chance of breast cancer. What did I just say normal was? 12. So pause and think about that. That's the epitome of flipping the statistic on its head, right? Normal women have a 12% chance it's going to happen. Women with a mutation have a 13% chance it won't happen. So the odds have swung dramatically in the opposite way. And unfortunately, mutation carriers who've already been diagnosed have a significantly increased risk of developing a second cancer. So once you're diagnosed, it's likely to kind of keep happening. So we'd like to prevent that initial diagnosis if we can. So genetic testing is available to see if an individual harbors one of these important mutations. So one of the common questions I'm asked is it BRCA or BRCA? Potato, potato, I do not care how you say it. BRCA is another way you can say it. Why did they call them the BRCA genes? BR for breast, CA for cancer. You see how easy that is? So it's just the breast cancer gene. So normally these genes prevent cells from developing into cancer. I want you to think about it like armor around your body. It simply protects you and says, cancer, you're not welcome here. Well, if I have a mutation in one of those genes, then I can't protect my own body and I end up with cancer at a higher rate. So when one of these genes becomes ineffective due to an inherited mutation, the cell can no longer prevent tumors from growing. This causes an increased risk for a variety of cancers. So when they first learned about these genes, they were called the BRCA genes because of breast cancer. Well, a few years later, they learned that they also cause ovarian cancer. And that's where that phrasing hereditary breast and ovarian cancer gene comes from. So again, if I start with ovarian cancer, about 15% of those women have a faulty BRCA1 or BRCA2 gene. A normal woman's risk of ovarian cancer is 1%. With this particular gene, it pulls you up to about a 63%. Now let's talk for a minute. Breast cancer is survivable. Ovarian cancer is often not. And so our language around ovarian cancer is such that we need to be more aggressive in our prevention of it. And so you'll hear me talk a lot more about how when there's an ovarian cancer risk, a woman having a hysterectomy or removing her fallopian tubes is a really important kind of component of that. This slide is probably one of the most important that I'll review tonight. So if you're thinking about, I wonder if I carry a BRCA gene, left-hand side, if you were diagnosed with any of those things, right-hand side, if your family was diagnosed with any of those things. And this is not a perfect science. This is kind of like throwing a dart. Do I get sort of close to one of these criteria? So on the left, if you've had breast cancer younger than 50, if you have had a triple negative breast cancer, that's a more aggressive, more likely to be genetic breast cancer. Have I ever had ovarian cancer? Am I a male who's had breast cancer? Have I had breast, ovarian, prostate, pancreatic, and I'm of Jewish descent? I'll talk about that a little bit more. Let me just pause and say every person of every race, ethnicity, culture has a chance of these mutations, but the Jewish population, the Eastern European Jews, have the highest likelihood of one of these mutations, and we'll talk a little bit more about it. What if I'm lucky enough not to have cancer, but my family member had breast cancer, had ovarian cancer, maybe two people on the same side of my family had breast cancer, maybe my grandma and my aunt. I have a male breast cancer survivor in my family, breast, ovarian, prostate, pancreatic, and 3 or more family members. Maybe you get a Facebook message from a long lost cousin that says, I have a BRCA mutation and I just wanted to let you know. That kind of thing happens all the time. And so communication in families is really important. And going out and warning individuals and making sure that they're aware. So around here, I train my staff to know these 3 words. If you are looking at a person's family history and you see anybody with cancer at a young age, think genetics. Now, young is defined as 50, right? 50 and younger. That doesn't mean if you're 54, we stop caring, and it doesn't mean that it's not a gene. It just means you begin to look at the family history a little bit different. Are there rare cancers? Breast cancer is superbly common. Pancreatic cancer is much more rare. So I'm looking for mathematically how many people are on the page, and does it make sense that that history is present? Let's take breast cancer. If there are 2 women on the page, it's not that hard to get 2 people with breast cancer in the same family if the rate is 1 in 8. I guarantee there are 16 women on that page. I'm just doing math. Well, ovarian cancer is 1 in 100. What if there were 2 people on that page with ovarian cancer? There are not 200 women on that page. And so you're just looking for something that exceeds what you would anticipate. And those frequent cancers where you just look at the history and you kind of get a sort of gut punch where you go, that's too much cancer. That family looks like something more is happening. This looks unfair. That's all much more likely to be genetic. Now, I'm not the author of this slide. I stole it, but I love it. So the idea is that we are all patients of multiple doctors' offices. Every year, we're going to go to doctor's offices, and that doctor's office is only as good as the information you tell them, right? So I work in the 3rd door from the left. I work in a radiology clinic where women are coming in and we're deciding mammograms and ultrasounds and those kinds of things. But as a patient, I see a GYN and I see a dermatologist and I get colonoscopies and I see my primary care. those doctors all need you to be telling them your history and your family history, because it's going to help them make good decisions around each and every one of those diagnoses. Okay, so this conversation is pretty easy to have with people. We identify who needs the genetic testing. You say, yep, I'm ready to go. I say, okay, blood or saliva. There's no difference in the mechanism. There's DNA in either body specimen. Some people are just afraid of needles, and some people don't actually make enough saliva. They have diabetes or dry mouth for other reasons, and it's hard to get enough saliva. Sometimes you live down the road, sometimes you're 4 hours away, so you don't want to drive in for the blood work, and so it's just sometimes logistics. We then ship it via FedEx to the laboratory, and then we have a second genetic consultation around what these results mean and what to do. So it's a visit, a specimen collection, a short wait, and then we talk again. So when people learn what I do for a living, one of the number one questions is, what would I do with this information? And more likely they write, what should I do with this information? Let's take it in 3 categories. An affected person might seek testing to decide what kind of surgery to have. Do I want a lumpectomy or a mastectomy? Should I take the chemo or the radiation? Should I have a complete hysterectomy or just my ovaries and fallopian tubes removed? And so there's a very practical reason they're doing it, because we're going to make a decision around surgery. An unaffected person may say, I would love to avoid all of that if I can. What's the best way for me to do that? And how should I manage myself? And everybody's doing it because they want to protect their children and grandchildren and siblings. So there's a generational component. People may say, well, if it was just me, I don't need to know this, but I would like to spare my daughters and granddaughters. The most famous woman on the planet to do this testing and test positive. So there's a moment where I put up her picture and people kind of roll their eyes and go, I don't really love her or her movies, right? I don't want you to think about her in that way. I want you to think about her as a human being. So at the time this story happened, she was a 38-year-old whose mother had died of ovarian cancer, whose grandmother, great-grandmother, and several aunts had all died of some combination of breast and ovarian cancer. She's married at the time, has children, a career, and would love to not get cancer. Now, she could have very easily done the testing, kept it private, nobody would ever know. And instead, she chose to write an article for the New York Times and was on the cover of every magazine telling her story. And there was a lot of ways she communicated her story, but I think this little snippet is helpful. I choose not to keep my story private because there are many women who do not know they might be living under the shadow of cancer. It is my hope that they too will be able to get gene tested, and if they have a high risk, they will know that they have strong options. You kind of can't argue with that, right? There's people out there who may benefit from my story. If they're also high risk, there's something they can do about it. So a common phrase that I talk to people about is, you can either be scared and do nothing or scared and do something. Scared is not a reason not to have these conversations. So we're either going to take an action or we're not. So in my line of work, we're talking about the right-hand side, the inherited mutations that people are born with. We can also cause mutations by our lifestyle, right? Our smoking, our drinking, our medications. I'm really talking about the things that are inherited from generation to generation. What do we do about them? As I've said here, we increase surveillance, we start at a younger age. There's some medications that people can take. You could do what Angelina Jolie did, where she had a mastectomy and a few years later an oophorectomy. That didn't guarantee she wasn't going to get cancer. It simply gave her the biggest risk reduction that she could have. So she walked in with an 87% chance of breast cancer. And when she was done with her surgery and her reconstruction, she walked out with about a 3% chance of breast cancer in her lifetime. She walked in with a 63% chance of ovarian cancer, and she walked out with about a 0.5% chance of ovarian cancer. So I do think that that matters intently. And so another way to look at at it is sort of, we don't want to take you way up into that redlined category. We want to try to pull the risk back if we can a bit. So following these medical management options can help patients reduce their risk, maybe delay the onset of cancer, or help detect cancer at an earlier, more treatable stage. So really, as you get into it, there's these columns of what we're talking about it. What are some of the additional cancer risks? Do I do screening or surgery? What's the impact on my family? And then some very adult things to be thinking about, right? Impact on my insurance, my medical insurance, my life insurance, my long-term care insurance. What does it mean to have these mutations? And is there anything I need to be aware of? The science that I'm going to review is a few pictures that kind of look like this. I like you to think of your DNA like a long strand of pearls, hundreds of thousands of pearls long. When I do genetic testing, we're essentially looking at particular pearls that have to do with particular kinds of cancer. Now, in actuality, every cell of your body has a nucleus. In the nucleus are those chromosomes. When we unwind it, we can look at that DNA, and I'm reading the code. This is what it actually looks like. So this is a picture called a karyotype. I just want you to notice that everything comes in pairs. So number one, there's two of them. Number two, there's two of them. Number three, there's two of them. Why? Because you have a mom and a dad who made you. And so BRCA1 labeled there is on chromosome 17. BRCA2 labeled there is on chromosome 13. There is no difference. They have exactly the same job, and their job is to prevent you from getting cancer. They're just in two different locations. So BRCA1 is higher risk. BRCA2, way more common. BRCA1, I expect to see cancers younger. BRCA2, a little bit more middle-aged. Few more men with breast cancer related to BRCA2. So there's some minor things that I can determine based on which one it is, but they're just two different locations. So sometimes people will say, can you have both? Yes, that would be really rare. I've seen, hundreds of thousands of patients in my career. I've probably seen that, under 10 times, but that's where there's devastating family history on both sides. And they typically, both sides are of Jewish descent because it's that much more likely that we're going to find it. So this is a wordy slide with a lot of numbers. I don't want you to get married to anything that's here, but I just want you to kind of see that the risks are enormous. So look at that second line, female breast cancer by the age of 70. With BRCA1, it's 87%. With BRCA2, it's 84%. It's really splitting hairs. There's hardly anything different there. I'll go down a couple. Ovarian cancer by age 70, 63% with BRCA1, 27% with BRCA2. How about prostate cancer? About 1 in 5 men with these genes will end up with a prostate cancer. Now, I'd like to comment that prostate cancer is really common, right? Lots and lots of men get it in their lifetime. This is an earlier, more aggressive, more life-threatening form of the prostate cancer. So we're not talking about 85-year-old grandpas. We're talking about 35-year-old sons that we need to warn and communicate about these sorts of things. Male breast cancer, it's slightly elevated with BRCA1, measurable with BRCA2. About 7% of men will end up with breast cancer. Remember, what's a normal woman's risk? 12%, 1 in 8. So to have a man walking around with a 7%, that's a decent number that we need to be aware of and would be recommending mammograms and ultrasounds and self-breast exams. What do we do about it? So here, what I want you to just see is that if we knew a woman carried this gene, by the age of 18, we're going to teach them to do a self-breast exam. By the age of 25, they're getting a clinical breast exam. By the age of 25, they're getting an MRI. By 30, they're getting a mammogram and an MRI. They do that up through about age 75. People can decide to have their breasts removed and their ovaries removed and a whole bunch of ultrasounds and blood work. That is a lot of work for people in their lifetime and a lot of appointments to keep track of. That's my job in the high risk department, is to make sure people are doing and adhering to these things. The alternative is sit and wait for cancer to happen, and it's almost always too late. So people will do this bullet point list for that reason. What do we do for men? Well, we're teaching them about how to do a breast self-exam, which most men are not going to do in general population. We're teaching them about a clinical exam. We're starting to do prostate screening at an earlier age. We're talking to men and women about what is in your body, what are the signs and symptoms of cancer. They can cause pancreatic and skin cancer, so go see somebody about it, and then have conversations with your children and grandchildren so that they're really aware of it. From 1995 to 2014, we only knew of BRCA1 and 2. So I was a two-trick pony. I knew about those two genes. That's all I needed to learn. And one day in April of 2014, I went home and I came back, and now we were doing 25 genes. And I just had to learn all of them and know what they did and learn how to counsel. Why did we do that? Because there's a whole bunch more genes that can cause cancer. Way more cost effective to do it at one time on one panel instead of thousands of dollars for multiple tests. This is my favorite slide tonight. So on the left-hand side, let's just pretend a patient comes in because they have breast cancer. And they say, well, I already was tested for the BRCA genes and they were normal. Why would I need any more testing? Because look at all those little petals in that flower. Those are all different names of other genes that can cause breast cancer. P10, ATM, PELB2, CHEK2, NBN. All of those can cause breast cancer. So when a person says I was negative for BRCA, I retort with, that was old science. There's a lot of other genes. Now, what if a person says, I've already had breast cancer? Why in the world do I care if I have one of these genes? So let's pretend the woman on the left with her breast cancer does testing and is found to have a TP53 mutation. Now let your eyes go to the right-hand side, put the TP53 in the middle. She's going to survive her breast cancer. What else is she at risk for? Ovarian, gastric, colon, pancreatic, melanoma, and endometrial cancer. So I'm so glad, lady, that you survived your breast cancer, but look at all the other kinds of cancer that you now need to be aware of. And she wouldn't know that unless she did the genetic testing. And I hope that's clear and I'm explaining it in a way that makes sense. This is the busiest slide of tonight, but what I want you to notice is across the top are common organs that can have a genetic component: breast, ovarian, colon, uterine, and so on. And along the left-hand side are the names of genes that can cause those kinds of cancer. So let's go really easy, go all the way to the bottom, RAD51D. What does it cause? Ovarian cancer, okay? So that person knows they can target all of their attention on an ovarian cancer. Let your eyes go up a little bit. Let's say CHEK2. That is a breast, colon, prostate gene. Okay, they got to go a little wider, a few more organs, but we're going to pay attention to those. Let your eyes go up a few more. TP53 is the absolute worst gene on the planet to ever counsel anybody about, because every single organ, those 4 individuals have a 100% chance of cancer by their 70th birthday. The only surprise is which organ is it going to hit first, because it's going to hit something, right? Let your eyes go up further. MUT-YH is a colon cancer gene. The BRCA's at the top. You see breast, ovarian, skin, pancreatic, prostate. So if a patient walks in the door and it's breast cancer, so let your eyes go up to the top, there's 10 or 12 genes that it could be, right? If a person walks in and it's ovarian cancer, there's 5 or 6 genes that it could be. But is it an ovarian gene that causes breast, like a BRCA? Or is it an ovarian gene that causes colon, like that second column, MLH, MSH2, MSH6? So if you walk in with ovarian, I don't know what to warn your relatives about until I do the genetic testing and kind of go from there. Now, maybe your family history already sorted that out for me. Maybe your family history already makes it obvious. But sometimes people have very small families. They don't have a lot going on, so I don't always know. This is the most sciencey slide, and then we're going to start to round to some more fun things in a moment. But I want you to notice that there's a bunch of genes that can cause breast cancer. The blue number is your likelihood, if you had that gene, of getting breast cancer before the age of 50. The orange number or red number, depending on what it looks like on your screen, is your lifetime likelihood of breast cancer by your 70th birthday, okay? So let's pick Pell B2, it's about halfway over. It's a 17% chance by your 50th birthday and a 58% chance by your 70th birthday. So when are most people diagnosed? Between 50 and 70. You see how to interpret that? That TP53, 84% by their 50th birthday, only 1% more between 50 and 70. So those are superbly young women with their breast cancer. Go all the way to the right-hand side, NBN. That's a puny little, tiny little gene, but it still gives you a 1 in 3 chance of breast cancer. You would want to know that. That's also a gene that gives prostate cancer. So that can help the men in those women's lives know something about it, okay? So how do we decide what we're going to test? We decide what we're going to test in these 2 categories. How likely is it to cause cancer? That's called the penetrance. I think about it sort of like a pendulum swinging. I want to test you for something that has considerable impact on your risk. I'm not really worried about minor little risk shifters because they're not going to change our behavior. So if something increases your likelihood of breast cancer 2 or 3-fold, I'm going to know about it and want to know about it. And then there has to be something where it's clinically significant. There's something we can do about it, right? I don't just want to make you worried and make you stressed out and lose sleep and at 2 a.m. be worried about your cancer risk. I want to say, okay, you have a cancer risk of colon cancer. I need you to get your colonoscopy at 40, and I want you to go every 5 years instead of 50 and every 10 years, right? So there needs to be some kind of step we're going to do. Cancers that are genetic, is that list there. Notice how other than melanoma, I don't put skin cancer. That's because that's usually sun exposure. Notice how I don't put lung cancer because that's usually I smoked, or liver cancer because that's usually I drank. It doesn't mean that everything is behavioral in those organs. It just means it's less likely to be kind of a genetic component. Now, we lecture like this a lot. So inevitably, when I'm speaking to a group like this, somebody has already done genetic testing, somebody already has their test results, and somebody's already thinking about what that looks like. So I want to just bring up, how can the test results come back? So look at the extremes, look at the negative and the positive, because those are the easiest to describe. Negative, I didn't find anything. Your cancer is either because of aging, environment, or a gene that we have not discovered yet. So remember how I said it went from 2 to 25? It is now at 91 genes that I can test for. And it's only going to grow from there because we have 30,000 genes. So I have the best job security on the planet because I'm going to keep coming to work and there's going to be more genes to communicate and talk about. Go to the opposite end, the positive. I found something. This is hard for people to digest. It's stressful, but I promise now it gives us information. We kind of know what we're up against with the enemy in that sense, and we know what we need to do in terms of screening. Now let your eyes go to the question mark or the gray. Whenever you do science, there can be things that you're not quite sure, you haven't quite seen it in enough people. It's called a variation. So another way to think about it is this slide right here. Sometimes we're in the middle and we're not quite sure, is this a concern or not? So using this latter approach, it is a benign change within the DNA. We're not really sure. Over time, we'll learn. If we are reassured that it's nothing, we come down the ladder and we're not worried about it. If over time evidence mounts where we go, uh-oh, this is a concern, then we climb up the ladder sort of in our risk. And that's part of the counseling and my job to kind of communicate. I like black and white better, but I land on gray a lot. About 1 in 4 people ends up with some kind of minor alteration. And then the art of counseling becomes really, really important. Cost is a very important question, and I always like to put this in. So the consult is typically covered by insurance. Any human being can talk to me, and it's usually just your copay. I don't know of an insurance around that isn't going to allow you to just talk to me. So Most of the time, I urge people that if they're interested, make an appointment, we chat, we personalize, and maybe you land on not doing any testing, but at least you were educated around what those risks are. If genetic testing is covered by insurance, it's subject to whatever your copay or deductible is, and I'm able to explain that to you during that consult where we're communicating. The labs today all have a self-pay option. And this is if I'm adopted and I don't know my family history. This is if I don't have insurance. This is if I have a huge deductible and I don't really feel like wasting the huge deductible on this test. You can just do a self-pay, let me pay for the genetic testing. And right now it's $250. Get your questions ready because we're almost to that point. I have a few more slides and then I'll be ready for your questions. So there's 3 types of genetic testing. There's what I'm talking about with the stars there, hereditary cancer running through a family. There can also be prognostic testing once you have cancer. How aggressive is this? How likely is it to come back? What chemotherapy do they need to use? Is that last column, that companion diagnostic. So some people, every time we talk, have had cancer, they did some genetic testing. That was on the tumor itself. I'm talking about mutations that are passed on from generation to generation. It is old science to only look at your mom's side of the family, that second bullet point. Your dad is an equal part of you. And so we do really need to look at mom and dad's side of the family to kind of get at risk. Those prognostic tests are predicting tumor aggressiveness. They look at the expression of that tumor in your body. Has it metastasized? And now there are these companion kinds of tests where they can figure out the best chemotherapy to fight a disease. I always like to talk about when I'm not part of the equation. So when somebody chooses to do testing through a company like 23andMe, right? I will honestly say that these labs are accurate. You can go to Target, you can pick this up, you can spit in the tube and you can send it back. What I want you to know is that it's very surface level. It just doesn't go as deep as what we can do in clinic. So it assesses only 3 of the more than 1,000 mutations that are out there. So you remember my analogy that's like a long strand of pearls, right? When I do genetic testing in a clinical setting, we're going pearl by pearl by pearl, looking at all 1,000. When somebody does a 23andMe, 3 pearls are looked at, and they're not 3 random pearls. They're the 3 most common pearls where we would see a problem, but specifically in people who are Jewish. So I am not Jewish. My heritage is sort of Northern European. I have around a 1 in 300 chance of carrying a mutation just based on my heritage. If I were Jewish, my risk would be 1 in 40. I'm almost 10 times more likely to carry a mutation just based on where my relatives came from. So the third bullet point, a negative result does not rule out the possibility that somebody actually carries a mutation because they just didn't look at everything, okay? So if I have done my job tonight, you should be able to answer these questions. I've already had cancer. Why should I get tested? Because I can warn my relatives. There can be other risks of cancer to me. I have a family history of cancer. Why should I get tested? So that I do the appropriate screens at the appropriate times. I monitor and watch my body and hopefully prevent those cancers. Does a positive test result mean that I have cancer or I will have cancer? No. It's a pendulum swinging that tells us what those risks might be. So some genes are going to give you an 87% chance of cancer. Some might only give you a 30%, but it doesn't mean it's 100%. How do I get tested? You talk to your doctor, your primary, your GYN, and you reach out to a genetic counselor, somebody like myself. We do see men and women, all different ages, all different kinds of cancer. Results take about 2 weeks to come back, so it's not the world's fastest test, but 2 weeks is a pretty standard turnaround time. How do I know if my insurance will cover the testing? Every insurance policy has a sort of grid or rubric. If you have cancer by this age or this many relatives or that sort of thing, or you call us and we'll let you know by telling us your family history and we'll sort it out. It can never cost more than $250. That's the worst it would ever be. It could only get better from there. And then my favorite question, why isn't everyone tested? Someday that will probably happen. That is the ultimate job assurance in me, is that probably in our lifetimes, everybody will be at least offered the option of testing. And then I just wanted to kind of open it up for any questions that you all have, and we can spend as much or as little time as you can think of for me. So what could I answer for you? I think you're muted. I saw you raise your hand, but saw you.
Okay, so I'm Liskin, and I have a pretty strong history of breast cancer in my family. I have 3 women in 3 generations who've had breast cancer. A grandmother who reportedly died of breast cancer at around age 50. You know, it was diagnosed too late. It was before treatment was available. My mother had double positive breast cancer, diagnosed at age 77, maybe 78, was successfully treated. My older sister, unfortunately, had triple positive breast cancer at age 73, was successfully treated at the time, but it's returned 10 years later as a double positive metastatic breast cancer. And then finally, at least one aunt on my father's side had breast cancer. Now I exercise a lot. I watch my diet. You know, I try to stay healthy, but my sister was tested for the BRCA genes and many of the other genes. And they were all negative. So
is that the sister who had cancer or a healthy sister was tested?
No, the sister who currently has cancer.
Yep. So there's a couple of things here, right? And one, I'm sorry that has to be the legacy in your family. That's a lot of breast cancer, but you're doing everything you're supposed to, right? You're aware of it. You're part of a group like this. You're getting your screening, you're eating well and exercising and all the things that you can control, because you can't control the other things, right? There's a couple of things. Several of the ages that you commented on, people were in their 70s. What did I say the most common cause of cancer is? It's age. So even though it feels like they're close together, even though it feels like there has to be a pattern and a reason, when people are in your 70s, it can just be aging. The most concerning thing you said was your grandmother at 50, right?
Reportedly, yeah. She was long gone by the time.
And so the thing that I would add is you started by saying she was 50, and it was caught too late, right? In that era, they didn't have mammograms like they do today. They didn't have the ability to look and to monitor, but to have it be an extensive cancer by 50 means it was there in her 40s, and that's early onset cancer, right? So even though if today we could have found it and successfully treated it and had a different outcome, the concern is that way back then, they didn't have that ability, and that could have been genetic. So I'm happy that your sister was negative, right? And we didn't find anything. Her cancer could have been aging. Your choice is keep doing exactly what you're doing. Or you could say, you know what, I'd like to make sure that I'm also negative. You know, mathematically speaking, you very likely are. So I never want to overtalk the test. I don't want to make it sound like you have to do this, because mathematically you're probably also negative. However, is there a slight chance that grandmother passed something on to your mom and passed something on to you? And because of your very thoughtful approach to life and making sure you're doing everything well, it may just be that you've gotten the luck of the draw and not gotten cancer at this point. So you are a candidate for it, and you have enough family history to certainly warrant it.
Can I ask one more thing? And I hate to hog this, but the aunt who had breast cancer, I believe she died of breast cancer. I don't think she was in her 70s at that point. I think she was she was certainly beyond 50, but that increases the risk as well. You mentioned.
It does, right? Because again, you're looking at the whole picture, right? So if it was just that aunt in her 70s, we're not having this conversation. But
Right.
it's the aunt on the background of the grandmother, on the background of your sister, right? So you take the whole picture where you go, that's a lot of people with breast cancer. And that's what it is it's not a solo, you're just building almost a pros and cons case, right? And you're going,
Sure.
wow, there's a lot of people there. Yep.
And daughters, then should we be having our daughters have the testing?
So you would be tested, and if you were negative, you cannot pass on what you do not have.
Okay,
to your
perfect.
children,
Okay,
right?
yeah.
So you
Oh,
need to
that's
cut
good.
it off in a generation. Now, unless your daughters have something coming from their father's side of the family.
Right. Okay,
So
got it.
you've got to look at both sides and figure that out. Yep.
Thank you. That was really helpful. Okay.
Yep, no problem. Who else has a question for me?
Kathleen?
Thanks so much. I do have a question. In the case of a recent diagnosis and a genetic testing, I don't mind disclosing. I recently heard that I was negative for the BRCA genes, but is it? Yes, that was a relief. That's a good thing.
It's a great thing.
It's a lot, right? But in terms of the type of testing that's conducted in that circumstance, and I realize you might not be able to comment on this, but is it standard to test for, I guess, what is the standard number of genes
Yeah.
to that are tested for? You know, should I go back and ask about the TP53? And I guess I haven't obtained my actual results yet, so of course I'll ask for those.
Yeah.
But I guess I'm not sure about how robust the testing is beyond BRCA genes in that circumstance.
So I want you to generally breathe easy. It is standard of care to cast the net wider, right? So there was a period of time where we did BRCA 1 and 2 only. And then if we were really worried, then we dipped further, right? But that has gone away. And now it's very standard of care to dip wider, right? So Kathleen, I'll share my contact information with you. And if you want to get a copy, I wish I could hug you right now. If you could get a copy of that report, I would be happy to review it with you and look over it. But you're looking for a couple of things, okay? You're looking for the number of genes. So it's pretty standard to do at least in the 40s. So 45, 48, depending on the company, we could walk into a whole bunch of different grocery stores and get milk, right? So we could go to Tops and a Wegmans and a ShopRite and a Whole Foods and a whatever, and we can get what we need. There's different labs that do genetic testing, and it's kind of geographical and insurance based, right? If you have Excelis, I got to send it to one of these two places. If it's this, I got to send it here. So there are standards of what they typically order. So I'm confident that you're negative for a TP53, but it's how many other things are probably there. So your actual physical report will tell you that. And if I can be of any help, I'd be happy to look at it and communicate. But you're just looking to see, was it about 45, 47, somewhere in there? We expand to larger number of genes, the more complicated the family history is.
Okay, so in this case, without divulging too much, there's a significant history of colon cancer. So I think it would warrant.
So that second column where it was the different genes, there's a group of genes called Lynch syndrome, LYNCH, that cause breast and colon. And then that CHEK2 mutation causes breast and colon. So again, it's standard of care for those to be on that 45 gene panel. So I'm confident that it was probably all there. And knowing that I try my hardest to make what I say memorable, but knowing that people walk out the door and forget it 2 minutes later, most of the time patients walk out hearing BRCA, because that's such a big deal. They just don't hear the other half of the puzzle, right? So it would be very odd for it to only have been BRCA, but the report will tell us that. So every group that I know of would test wider.
That is so comforting and just really helpful. Thank you.
Good. You're welcome. No problem. What else?
Yeah,
Yes.
hi. I do have a mutation. I have a CHEK2 mutation.
Yep.
And I've had both breast cancer and prostate cancer through the years. And it sounds like we know much less about CHEK2 than about the BRCA stuff. So I guess the question is kind of going forward, it seems like we learn more as time goes by. So
Yep.
for follow-up, should I check back in?
Yeah. So CHEK2 should really be called BRCA3. So if they were continuing the nomenclature, they would have kept going with something that was easy for us to remember, right? So it was the third breast cancer gene that was identified. It is known to cause breast, colon, and prostate. So your family history makes sense. Its presentation is a bit unique. It tends to be more middle-aged breast cancer. So people aren't 20s and 30s. They're sort of 50s and 60s, though there can be some 40s. It is typically found in people of Polish descent. So I don't know what your heritage is.
I'm Ashkenazi.
Yeah, so that would make sense, right? It is also something where it has a hallmark of causing a breast cancer and then 10, 15, 20 years later, causing the contralateral breast to have breast cancer. So when somebody tells me their history, so the woman who spoke first, who said, you know, this person had cancer and then this person and they got it again, CHEK2 is one of those ones that we think about. Now, it's either two cancers together, multiple locations, or one and then a few years later, the other. There are some studies recently that said maybe thyroid cancer is associated. And there's some studies recently that said maybe ovarian cancer is related, maybe skin cancer is related. So we know breast, colon, prostate. We're questioning thyroid, skin, ovarian. So to your point, should I communicate with the team more regularly to see if there's any new information? And the answer is yes. I would also argue, though, a team who's doing a good job automatically reaches out to people when there's new information, right? And so when the BRCA gene was just breast, and then we learned ovarian, we had to tell everybody. And then when we learned prostate, we had to run out and tell everybody. So you've got to warn people and communicate that. I do think the onus is on the healthcare provider, but healthcare providers have a lot on their plate. So I do think it's nice to partner with them and reach back out and communicate. The other thing about CHEK2, if you think about it like a long strand of pearls, right? There's a very particular CHEK2 mutation called 1100 del C. And so that's just a fancy way of saying the 1100th pearl is deleted. Del means deleted. And so anybody who has that particular pearl has the most severe presentation of cancer in their family. You expect a lot more cancer than any other pearl. So when I'm communicating with somebody who has an 1100 del, I need to let them know they're at the highest level of those numbers, right? Where if they have a different pearl that's altered, they're at the lower end. And so it's just knowing what one specific mutation you have. And so like I said to Kathleen, if there's a report that you have or you know what it looks like, it'll say CHEK2, and then it'll give you the language. It's usually which pearl and then what's wrong with it. So 1100 del C, if you see that there, that's called a founder mutation. 70% of people who have CHEK2 have that particular mutation. And it was found in one little village in Poland. And then people went all over the world and harbored that mutation as well.
Thank you.
Fascinating. Yeah, you're welcome. All right. What other questions can I answer?
I don't have any at the moment, but I look forward to reviewing the presentation later on and seeing how specifically it applies to my situation.
Sure. I'm putting in the chat the phone number to the clinic and my email address. So you're welcome to use either of those.
Thank you.
And I can send the
Very good.
slides to Jennifer too, if that's helpful. Just
Oh, please, yes, I would love to have the slides.
no problem.
Thank you.
You're very, very, very welcome.
Yes,
I told you I have the best job on the planet. It's very exciting. Because
been
it's
very
useful
helpful.
and
Thank you.
beneficial, and you can utilize it for sure.
Well, and so much is becoming known and so much progress is being made that it's, it's always interesting
Yeah,
Yeah.
for sure.
and helpful and so helpful to people. This was wonderful. Thank you.
But you're very welcome. My pleasure.
Jessica, if I can just underscore the previous comment, thank you so much. It's, the end of a long day. Everyone's working hard in one way, shape, or another. And I debated whether or not, do I have the energy to come? And I'm so pleased I did. I knew it would be worth it, but thank you. It's a
My
comfort.
pleasure. My absolute pleasure. Jennifer caught me shoving candy in my mouth. We were on first and we put ourselves on. I was like, sorry, hold on. Just part of our lives to get where we need to be at the time we need to. So yeah, reach out as you see fit or any questions that come up. And Kathleen, specifically to you being at the beginning of a journey, you got this, okay? You can do this. Nobody feels brave when they start climbing. Am I right, Bob? At the beginning of your journey, did you feel brave? No.
Thank you.
Not at all.
I got braver and it gets easier.
Yes, and then you look back and you go, look what I did. And I didn't want to do it, but look what I did. So when you're at the point where you have no choice, you just kind of got to do it. But the negative genetics is just a really good and amazing beginning point. So get that report, look at that number, and feel free, honestly, to email or call with anything, okay?
Thank you. I will. Thank you so much.
My pleasure. Jennifer, did we miss anything that you can think of?
No, there's nothing more in the chat. And if anybody, we'll do one last call. If nobody else has any last questions or comments, I think we can call it a night.
All right, enjoy your evenings.
All
Thank
right,
you.
Thanks again.
Yes,
Thank
thank you,
you.
everyone.
My pleasure. Bye-bye.
Bye.
Take care.